this training session, which is Step N, which is the program focused for the nursing education for the critical care medicine. And today we are going to talk on very important topic, which is pressure injuries in critical care. We all know that the patients who are admitted to ICU, they are always at risk for pressure injuries, especially because they are bedridden. Mostly they are elderly, they may have malnutrition, and many other risk factors are present. So it is very important that we, as a nurses, especially, should focus on both assessment and prevention of the this pressure injury, as well as the management of the pressure injuries. So for that, we have very esteemed speaker with us who is going to discuss on this very important topic, Dr. Prateek Koolwal. He is consultant critical care medicine at Jaipur, and he is a very learned person. And I hope after this session, we'll be much more uh, informed about this very important topic. Over to you, Dr. Prateek.
Thank you, sir. And thank you, Stephen Session, for engaging me for this nursing program. So today's topic is pressure injuries in critical care. So what is a pressure injury? A bed sore, also called a pressure ulcer or a decubitus ulcer. Injuries to skin, underlying tissue, resulting for prolonged pressure on skin. Pressure ulcers have significant impact upon patients' morbidity, mortality, and quality of life. Cause of concern for both patients and their families as a health professional and healthcare system. So what's the incidence of these pressure injuries you found in your critical care setup or in hospital setup? Prevalence rate is 4.7 to 32.1% for hospital population and up to 22% in nursing home population. Surveys showed that pressure ulcers prevalence from grade 1 to 4 was 18.1%. That is, grading from 1 to 4 reaching was 18.1% and 10.5% if grade 1 ulcer is excluded. Sacrum and heels were the most affected location, as we all know that. The cost estimate, which is the most burden part to the population and to the attendants, that causes a most harm on that is the home-based palliative care and the hospital and the critical care settings. In home-based and palliative care, prospective study in Kerala reported that median daily expenditure is 77 rupees, that is 1.2 US dollars, for pressure ulcer in home-based palliative centers settings for critical or for cancer patients and for critical care, with a median total cost per patient of rupees 2300 over course of healing of 56 days. The total cost incurred by the hospital for 21 patients with a pressure ulcer was rupees 58,000, with a median medication cost of at rupees 17,000, and the wound care material is 1,800. Hospital care and critical care settings cause a maximum effects on the cost effectiveness. And however, the cost effectiveness study from a tertiary center in India found a mean total cost per participant of pressure ulcer management is 43,000. So the key point is the mean daily cost in home-based palliative care is rupees 77. A total cost for per patient in 12 weeks of hospital-based studies is 43,000, and cost burden in substantial for families as much care is out of the pocket and home-based in India, and resource limitation in India ICU may both reduce the direct cost due to loss of intensive interventions and increase indirect cost. This is a pathogenesis, a vast pathogenesis of a pressure ulcer. So,
Just to add one thing.
yes, sir.
Yeah. So definitely the cost is very important. That the cost is because you have to take care of this a very important injury. But it is also very important to look from the patient's attendant's point of view and patient's point of view, If a patient who has been sick for very long in your ICU and the patient is getting treated and he goes well, but if the partial ulcer is there, then it obviously it acts as that the care was probably not appropriate. That is
Yes,
the
sir.
message which the attendants take away.
Yes, sir.
So that is why it is very, very important. Apart from the cost is definitely involved. But apart from cost, this is a very, very important thing, because it is a quality measure for your ICU, especially from the nursing point of view. And that is why we have to be very, very focused on this prevention aspect.
Thank you, sir. So, as a sir told about the cost effectiveness is important, but also the care cost is also the most important. So, moving ahead about the pressure ulcers and the pathogenesis and clinical findings, which is a most important part to understand that how it occurs, so that we can prevent it occurring. So the bed and wheelchair stretchers or seat is an external physical compression. Okay. An involuntary muscle movement and passive repositioning of torso causes a shear force, that is dermis and epidermis fixed though the contact with the surface while deeper tissues are moved. So the dermis and epidermis causes a harms. Third point is inability to move well as a aging skin, loss of elasticity, blood flow, and subcutaneous sweat. That is causing a friction loss. Fourth point, bowel and bladder incontinence, as we see in some patients of spinal injuries or having a involuntary loss of the bladder and bowel habits, causing an incontinence, diaphoresis, and wound drainage, causing a moisture and decrease in movements like in coma patients and neurological patients and post-surgical patients, limited mobility. So these are the five factors or intervening the pathogenesis of the pressure ulcers. So the more common is in age of 65. Risk factors are diabetes, peripheral arterial disease, immunodeficiency, steroid therapy, smoking, dementia patients, poor nutrition intake, circulatory disturbances. The grading system was from the National Pressure Ulcer Advisory Panel. So, above taking all the factors of 5 points, unrelieving pressure greater than the arterial capillary pressure. So, the pressure range that you have to kept is 1232 of the body surface area. If you keep the pressure more than 30, or it is compressing these parts of external physical compression, shear forces, friction, or limited mobility more than 32 mm Hg, that is above the arterial pressure, then this will cause a pressure ulcer. So this is small pathogenesis, but important to know because it will affect our treatment part. Disrupts the blood supply, deprives the tissue and oxygen nutrients, is also added to the pathogenesis part, lead to the pressure ulcer. So how the pressure ulcer? Stages of stage 1, stage 2, stage 3, stage 4, and deep depth as unknown, that is stage 5, which is not included in that, but it's the depth and unknown, which is not hidden, which is not seen, but it is hidden. So in stage 1, non-blanchable erythema of index skin and hurts the impending ulcer, which is most common, and which is, if you notify initially, then you can save this patient from the stage 4 part. Stage 2 part, partial thickness skin loss. Stage 3, full thickness skin loss, damage to the subcutaneous tissue, but not underlying the fascia. Stage 4, a full thickness tissue loss, which lead to a further treatment of skin grafting required, because it exposes the bone, tendon, and a muscle exposed part. Sludge and eschar may be present, often have a undermining and tunneling part also. And a pear or a butterfly-shaped scar ulcer is a Clenidy terminal ulcer, often precede to that because it's the most depth part of the ulcer, causing on a most harm to the patient. Depth and unknown is a sludge and eschar covers the wound bed and obscures the depth, how much deep it is. So it is the most dangerous. It's like occult part, that how much deep it is. Must remove the sludge and eschar for determining the stage. Stage 4 goes towards the osteomyelitis also. So this is the whole summary of the pathogenesis of the pressure ulcer, which is to be known to treat our patient. So, pathogenesis, unrelieved pressure, disrupts the blood supply to capillary network, delivery, depriving of tissue of oxygen, nutrients, and blocks the return of a metabolic waste. So, if you give the pressure more than that pressure required, it will disrupt the blood supply. So, the blood supply got disrupted, the tissue get deprived of oxygen, nutrients, and block the return of the metabolic waste. Complete inflow impairment, local ischemia lead to the pressure ulcer. So these are stages with the diagram. Stage 1, as I've already told you, non-blanching erythema with intact epidermis, like this. This is a non-blanching part. Only the with intact epidermis, epidermis is not lost. A partial thickness ulcer involving epidermis and dermis. This is epidermis is involved and small part of dermis is also involved. Full thickness of ulcer extending through dermis and subcutaneous tissue. This is the whole part. As you see, the epidermis is totally involved in our stage 2, and and dermis is also involved in stage 3. In stage 4, the deep tissue destruction involving the fascia, muscles, bone, and tendon. So this is the most hazardous part, which is difficult to treat and require a long treatment and high cost of treatment. A suspected deep tissue, that as I have told you, that is occult part, is the purple maroon localized area of a discolored intact skin or a blood filled blister due to damage of underlying soft tissue from pressure and the shear. The area may be preceded by the tissue that is painful, firm, mushy, boggy, warmer, or a cooler as compared to adjacent tissue. So if you compare this area with other area, it's totally can be a soft bogey type, a dough type, and a firm or a mushy type, and very painful. Unstable pressure ulcer, full thickness tissue loss in which the base of ulcer is covered by the slug, yellow, tan, green, brown, or a S-sharp in a wound of a bed, and the base of a wound cannot be visualized. What is the base is cannot be visualized with this area. So as I've already told you, the staging by the National Pressure Ulcer of Advisory Panel, I'm not discussing more because I've told you in a two pathway, in a pathogenesis also, in a diagram point of view also. So the above this all of pathogenesis, what are the main factors? What are the main contributing factors? Pressure, friction, and the shear. What are the risk factors? First of all, risk factors are the mechanical boundary conditions. A magnitude of a mechanical load. How much load are you giving to that area of a ulcer or to the skin part? Time duration of a mechanical load. How much area of a pressure for how much time it's applying. Type of loading, shear. Shear means what? How shear occurs? When you drag your patient more on a bed. Okay, when you take up and down your patient, that as you say that आज मेरे को patient को तो अभी आप please patient को ऊपर लीजिए. So if you are dragging, this is called shear stress. Pressure, you are applying a patient is bound to that pressure for a prolonged time. Friction, going up and down by the as a neurological patients come down again and again. This is called a friction of that skin area. So these are the internal strain and stresses. Susceptibility and tolerance of the individual mechanical properties of a tissue, individual geometry of a tissue and bones, individual physiology and the repair. How the repair of that patient is occurring on. If the patient nutritive value is very good, if the patient treatment part is going in a phenomenal way, that patient is improving side from his critical illness, then these ulcers are or these pressure ulcers get healed very fast, or their risk factors are very less, becoming a pressure ulcer. Individual transport and thermal properties like causes a damage threshold. So these all internal strain and stress and damage threshold can lead to the pressure ulcer. These are the risk factors that can be abandoned and can be stopped so that the pressure ulcer cannot be occur. So other potential indirect causal factors like older age, medications, pitting edema, chronic wound to the patient, infection, acute illness, raised body temperature. Other potential indirect causal factors, poor sensory perception, diabetes, moisture, poor nutrition, and low albumin. Other potential causal factors, immobility, skin status, and poor perfusion. These outcomes the pressure ulcer. So these all like indirect factors, these are the other indirect causal factors, and these are the other indirect causal factors, these all related to the pressure ulcer status of the patients. How you classify these risk factors? Intrinsic and the extrinsic factors. Intrinsic, most common is the progressive neurological disorders, pain, post-surgical patients, poor nutrition patient. Other, diabetes mellitus, peripheral vascular disease, decreased pain sensation. If the patient not having a pain sensation, that is the most debilitating part to occur a pressure ulcer, because he doesn't know that his ulcer is occurring or some bad wound is occurring or not. So if this pain sensation is very low, then it is very easy, easiest risk factor to occur a pressure ulcer. Corticosteroid therapy. Most of the ARDS patients, prolonged bedridden patients on prolonged ARDS or prolonged steroid therapy, autoimmune patients on a prolonged corticosteroid therapy. These are the most risk factors causing for the pressure ulcers. End stage renal disease, having a decreased perfusion to the skin, intrinsic age of the skin, loss of elasticity, change of dermal pH, and loss of subcutaneous fat. Extrinsic factors, as I've already told you, pressure on any hard surface, friction on the patient's inability to move the well in a bed, shear of the involuntary muscle movement. These are the most common sites. Pressure injuries are characteristically rounded with regular edges. The most common site for pressure injuries are supine. In supine, we can see at the 23% sacrococcygeal, that is this area, and 8% in the heel part, and 1% in the occiput part. Okay, so what this nurses acquire this knowledge from this, that every shift you have to see that these things or these part of your patients in every of your shift. If you have a 6 hour shift, in every 6 hour shift you have to see this. Okay, and when the patient from outside hospital come, you have to see these places. Sitting area 24% ischium and 3% elbow, and lateral part 15% trochanteric and 7% malleolus and 6% knee and 3% heel part. How you prevent and manage? The main part is prevention management. Whatever you do is your management, because you haven't prevented it, then you have to manage it. So prevention is a most cure part of this pressure ulcer. As sir already told you, if you have not taken care it properly, if not taken care in a initial time, it will lead to the management part, and which is very costly to the serve to the patient. Key element: risk assessment, skin assessment, prevention measures, and treatment. Risk assessment is done by the Braden scale, Norton scale, and Waterloo scale. So the most common scale that we use in our ICU, I think in all ICUs, is Braden scale only. So this is a Braden scale. So in the Braden scale, these are 5 points: sensory perception, moisture activity, mobility, nutrition, and friction in the shear. Most of the patient, when you start seeing in a good critical care setup, comes in part of a moderate risk and or a milder risk. If you miss this moderate risk, it will very easily transform to the severe risk, which includes completely limited unresponsive patients, constantly moist skin. When the patient passing a urine, you have not cleared it, or the diapers as nowadays diapers are not used, because diapers causes the pressure ulcers more easily, because it becomes occult. We don't know how much time it was getting wet, so the diapers are not used. But in previously, when diapers are used in home based settings or a nursing care based setting, it will easily reach to the severe score. A bed fast, confined to the bed, completely immobile patients, very poor, never eats, or very poor nutritive value patients, and requires a moderate to maximum assistance to move from the bed. Norton and Waterloo scale is another the scale. So this is a very vast scale. You can get these scales. You don't have to remember these scales. You can put on your charts, or you can bring out the printout charts and put in your file to check out the scoring of these scales. Okay, evidence of the risk assessment. So these are lots of evidence about the risk assessment. What this says, that is this score or scale is important. Scale is important, but wound management training and clinical judgment is more above the scale. If you see the wound management, if you have a training scale is very good in your hospital and a clinical judgment is very good, then a Braden scale comes inferior to that. Okay, so in this all study, it's come about that your scaling part is not that much evident when your clinical judgment comes about. So whenever you come on your duty, clinically assessment of that score of that patient's bed pressure areas is more important and a high quality as compared to the scale. But when scale and wound management combined, it becomes a high quality of index. This is this is the scaling, and this is the evidence of risk assessment of all of under the curve area, that is Braden scale, Norton scale, Waterloo scale, and a Cubic Jackson scale. But the most common is a Braden scale. As you see that if you inherently takes a Braden scale only, that is have a very low quality of index. But when you acquire with your clinical precision, it becomes very high quality. So how you prevent and
Yeah.
manage?
So Prateek, I would like to add some
Sure, sir.
points here.
Sure, sir.
Yeah.
Sure, sir.
So this is very important that from exam point of view and from like practice point of view, that we should know these scales. And Braden is obviously the most common and widely used scale. But we understand from all these slides and the information which is available to us that these are going to tell you about the risk factors. But more than that, it is going to sensitize the nursing team that okay, this patient is at higher risk and we have to be much more careful in managing and preventing the bed sore. So that is what is the actual message which comes out from these scales. Okay, uh, it never means that if a patient is at a lower risk, that means that we should not take care of the bed sore prevention in that patient. So we have to be at our highest uh, care when whether the patient is at low risk or high risk, we have to provide our best care to all of our patients.
Sure. So, moving towards our after the risk assessment, prevention, the management part, that is the most important. So, how you prevent it? A nutritional support, frequent repositioning, support surfaces, preventive skin care, application of skin and protective dressing, cleaning and debridement, role of nurses, which is the most important. It's not about the role of nurses, but also the role of doctors also, that in every shift, whatever a resident doctor or doctor around coming should see, the back area or the pressure area is the most common to causing a pressure ulcer. So evidence in nutritional support. Supplement containing a protein, fats and carbohydrates, mineral, vitamins versus standard diet. So only to use proteins, fats, carbohydrates, minerals and vitamins that you give your protein powder, or you give a standard diet. So the study shows that a no potential clinical difference between the two for reducing the incidence of pressure ulcer. The direction of effect is favored a supplement. That is, you have to supplement overall to your patient. Okay, no evidence found for the following outcomes of rate of development of pressure ulcers, time of to the development of pressure ulcers, time in hospital or nursing home center care, or a health related quality of life. So it doesn't mean that if you give these all nutritive value, it will not cause a pressure ulcer. It will just add on to the part according to the care of nurses and to the other support system. So it is included to the other support system or the other prevention parts also. Supplement containing a high amount of protein, arginine, zinc, antioxidant versus standard diet. Study showed no clinical difference. It's just added to the cost. Both diets for reducing the incidence of pressure ulcer. but the direction of estimate of effect could favor a supplement, very low quality of index. Second point, positioning. What the article says of 2022, the prevention of pressure injuries in positioning of mobilization of patients in ICU says that adopt a patient repositioning protocol, customizing it based on a patient level of autonomy, that is what the patient wants, and availability of your resources. Unconscious patient must be maintained in lateral decubitus position, not in supine position, because they can't turn over. And any repositioning must be carried out by switching from one side to other in accordance with the clinical conditions. If the patient doesn't allow the left side turning, you can go for right side turning, but do the positioning to the patient, okay, to avoid the pressure injuries. So these are the positions. Upper limb positioning, keep the upper limb abduction at the angle of less than 90 degree if necessary for the therapeutic purposes. So the lower limb positioning not be hyperextended or spread more than 30 degree in spine. Head positioning, carefully assess in each individual case the relationship between the expected benefit and possible risk of different degree of head tilts. Okay, so why is head positioning important? Sometimes you see in neurological patients the head got tilted towards the right or left side, so it will cause a pressure also to your ear lobes and toward the side part of it. So you have to keep your patient neutral part also. Every 2 hours changing of position of head also, like left shift or a right shift. Okay, but if it is trauma patient, then you have to keep for the neutral position. So these are the conditions or the type of a patient you are giving a positioning. Okay, in trauma patients, you give a different position. You don't, you keep your patient straight, keep your spine straight. If there's a spine trauma is there, if your neck trauma is there, then you keep your patient straight to avoid the any hyperextension of the spine. Okay, if there's burn injury on the back, you keep your patient on a right or left lateral decubitus more as compared to the supine. Okay, prone position in mostly in ARDS patients is a is about to be more cumbersome and causing a serious complication of pressure injuries to the ortho part. So the prone positioning is usually safely in patients of severe respiratory failure in ECMO patient. The prone patient must be placed in reverse Tendelbach position with trunk tilt to 5, 10 to 10 degree as we all do in a ECMO patients. In supine, the trunk can be tilted to 10 degree to 28 degree with increased risk of pressure without increased risk of pressure injuries. So this is an example of how you keep your patient on ventilator, how you avoid the pressure injuries, and how these can be done. So the early mobilization, active
So
and
just
passive mobilization
Prat-
interventions are aimed at recovering a muscle tone, coordination, and range of joint movements. Because if you do not do early mobilization, it's causing a stiff to the joints and also the pressure injuries. Acute lung injury symptoms present in intensive care unit associated with weakness also. So the expert space statement says that ARDS patients on invasive mechanical ventilation for more than 24 hours gain benefit with early mobilization. So it is youth most important in our ARDS patients because most of the patients we acquire in our critical care is mostly the respiratory patients. Expert statements also say that place at risk patient for pressure injury on air mattress. Use of viscoelastic foam mattresses. If it is not possible, to reposition patient at interval of less than 4 hours. If you can't use, if some patients or if you can't use your foam mattress is not available to the some areas, but so you how you can avoid it, you can do the positioning in less than 4 hours to the patient every 4 hours. Okay. Other part is skin protective dressings. These are nowadays used more. So the hydrocolloid dressings have adhesive compounds in the combination with water resistant of outer layer. So your water is not getting reabsorbed to the surface of the skin, causing moisture of the skin. You avoid that and are normally used in wound care and are frequently used in combination barrier with creams, prevent additional moisture exposure. Application of silicone foam dressings to anatomical areas frequently subject to pressure of friction or avoid the shear stress like heel and sacrum should be considered as it is shown there. here. So skin protective dressing, a dressing protocol is there. If the ulcer is formed or some patient coming from outside having a bed sore, what is the protocol for a dressing for it? Check and assess under the dressing to every shift. As I've already told you, in every shift of nursing, you have to check and assess the dressing at every shift and document the findings. Peel dressing the back, assess, reapply. Ensure the borders of dressing in smooth and no wrinkles. Document on skin bundle, that is surface, skin, keep moving, incontinence, and nutrition. So every nursing staff has to ensure these bundles. See the surface of the area, see the skin area, keep is the patient is moving or rehabilitating to bed area, incontinence and nutrition. Remove and replace dressing after 3 days or when necessary. When the dressing is soiled, you have to change your dressing. Replace dressing if patient is still at risk. Skin protective dressing, what the expert comment says that apply a multi-layered polyurethane foam preventive dressing with a silicone to the areas at risk of developing injuries, bony prominences, area of subjected to pressure, rubbing and shear forces. AORN guidelines in 2017 says that preventive dressings in a bony prominences or the other areas of subject to pressure and friction and shear forces is useful. Cleaning and debridement. It is essential to keep the wound clean and prevent from the infection. Stage 1 wound can be gently washed with water and mild soap, but open sores should be cleaned preferably with the normal saline, not with any antiseptic agent, because povidone iodine can also be a source of bacterial growth. Debridement required only in stage 3 and 4 with necrotic tissue, followed by cleaning of wound and application of moist to the absorbent dressing. Apart from these, skin graft, bioengineering skin, incision and drainage is the other part of the management that could be done for the, if you find any pressure area that is having a abscess that to be drained so that it cannot harm the other area of the part of the skin. So this is one example, having a pressure in occiput area. We have done the skin grafting and then erosion and then grafting is done and then the part is got healed. This is another on a back of fascia, the most common, the patients having pressure on the heel area. So the how the skin graft is taken, the skin graft is taken from this part and another part of the skin got covered from this area. This is called a skin grafting in a grade 4 part, having a tendon, fascia is also showing. The advanced therapy is hyperbaric oxygen therapy. Hyperbaric oxygen also used topically to treat pressure. These are used in higher centers. These are used in extensive areas who can use that costing also. Specifically constructed devices equipped for control pressure and automatic relief valves, suppressed bacterial growth, enhanced granulation and epithelium formation. This is how the hyperbaric oxygen therapy works. This is the whole chart of how the hyperbaric oxygen therapy works. Increase of reactive oxygen species and nitrogen species. Then increased wound growth factor synthesis, elevated tissue, angiopoietin, the basic fibroblast of growth factor. Okay. Then a stems of a progenitor cells. Okay, this also help in a bone marrow to increase the peripheral site of stem progenitor cells content and increase the gene product. This is very advanced type how the hyperbaric oxygen therapy works. You can use in advanced like stage 3 or stage 4 to heal the part of the damaged part of the bed sore. This is the most important, the role of nurses. The nurses should continuously assess the patient who's at risk of a bed sore. Assess the patient for the predisposing factors of the bed sore development, skin conditions at least twice a day, as Sir has already told you. Inspect each pressure site, palpate the skin for increased warmth. Need it and you have to do it. Inspect for dry skin, moist skin, break in skin. Evaluate the level of mobility. Evaluate the circulatory status. Determine the presence of incontinence. Evaluate nutritional and hydration status. Note present of health problems. Prevent it rather treating it. Intervention for patient with poor nutrition. Provide adequate nutrition and fluid. Assist with intake as necessary. Consult dietitian for nutritional evaluation. Other interventions: evaluate the ulcer progress every 4 to 6 days. Assess the physician and surgeon in debridement if it is required. Educate the patient and family regarding the risk factors of prevention, the bed sore if your patient go for the home care. Intervention to avoid the friction and steer. Reposition the patient using a draw sheet and lifting of the surface. Never drag your patient. If your patient came down in your bed, never drag your patient. Rather, use a draw sheet to lift your patient to upward to make a position to the patient. Use proper positioning techniques and avoid dragging the patient in bed. Interventions for patient with decreasing activity and mobility. Established individual turning schedules. Changing position at least once in 2 hours, as you have as everyone in their ICU having a plate of 2-hour positioning to the high risk individuals and patients. Intervention for a patient with decreased sensory perception. Assess pressure points for sign of bed sore development. Provide pressure redistribution surface. Intervention for patient with incontinence. Following each incontinent episode, clean that area, dry that area thoroughly so that you avoid the pressure ulcer formation or injuries. Protect the skin from moisture barrier ointments. So this is whole flow chart of a pressure ulcer where you treat, protect, and treat. Okay, remove the possible and removable causes, improve nutrition, treat control comorbid diseases like diabetes, cardiac renal, and COPD patients, and wound therapy. If slug is absent, epithelializing superficial ulcer, dressings to be done. If sign of tissue and systemic infection is there, antibiotics to be used. If slug is present, then debridement to be used. If all three is maintained, then healing, continue preventions like avoid ill-fitting footwears, mattresses, cushions, protective devices, improve nutrition, and control and morbid illnesses. If non-healing part is there, then superficial healthy ulcers, no exposed vital tissue, skin grafting is there. Is heavy slurs is there, that is a negative pressure wound therapy is required, is effective, then skin grafting is not effective, then go for the local flap. Okay. This is a whole algorithm. You can take a picture of it for whole algorithm of the management of pressure ulcers. Okay. And complications after this, if you're going avoiding, if you're not treating it properly, then it causes cellulitis, bone and joint infections, cancer in some of the tissues of the skin area, because as you see the stem and progenitor cells causing the malformation of the cells and can lead to the cancer part also and sepsis. Conclusion: avoid contributing factors, early recognition of warning signs, determination of stage evolution, risk assessment, prevention and management, role of nurses, management of complication, and the most important is prevention is better than cure. These are my references to these that I've taken the slides from. So an ounce of the prevention is worth of a pound of a care, and this is a more important pearl of wisdom. Thank you. So these are the some brain teasers and MCQ that to be used. So over to you, sir. Then after that, I can use the MCQ, sir. Your points towards the pressure ulcer, sir.
Yeah, thank you, Prateek, for such a nicely presented on a very important topic. So I think we should go to the slide where you showed the patient where we are giving him a position for preventing bed sore. Can you
Sure,
show
sir.
that slide? That is
Sure,
probably
sir.
very important slide.
Sure,
You
sir.
can, yeah, this one. So we can see here the all the things which have been done to prevent the pressure injury. Okay, we see here that a proper position has been given to the patient. The patient is not supine. There is elevation of the head end has been done. and all the parts where the pressure injury can occur, it has been well padded, like we see here in heels, and it has been well supported with the help of all the soft materials. Okay, and if we are doing it every 2 hourly, like supine, and we see this as a wheel of care, every 2 hourly, if we are doing this thing, the chances of bed sore or the pressure injury becomes very, very less. Also, to look here is the position of the limbs. Okay, so position of the limbs, especially the lower limbs, is very important. So keeping a pillow between the two knees is very important. Why? Because if this is not there, then it can cause injury to the sural nerve. Okay, and if the sural nerve is, or the superficial femoral nerve, it gets damaged, then the sensory part, the sensation of the lower limbs, especially the heel area and the foot area, will be reduced. And if that is reduced, the chances of pressure injury will increase very high. Okay, so that is why putting a pillow between the two knees is a very, very important thing, which we must all follow it. Okay. The other very important things which Prateek has already covered is that the dressing has to be done with the help of silicone dressings. The routine dressing is done with the help of gauze pieces and all, so that should be avoided. And making a position, we should always lift the patient with the help of sheet or a drawer sheet, and we should never drag. These are very, very important things. And one last point to add about was about the hyperbaric oxygen therapy. Although it has shown a lot of promise in improving, especially the grade 3 and grade 4 pressure injuries, but it is very difficult to do in a patient who is already in ICU, and especially on ventilator, because it cannot be done in a patient who is on ventilator. The patient cannot be taken to the HBOT chambers. But once the patient is stabilized and he is not requiring any ventilator support or any other support, then definitely we can consider HBOT at the centers which is available. And we should always consult with the plastic surgeons and what is their uh, opinion about the requirement of HBOT in such patients. Right. So these are very important points. Uh, One differential diagnosis regarding pressure injury is incontinence associated dermatitis. That is also very important skin related problem in patients who are in ICU. And this happens because if the patient is having incontinence, whether it is a stool incontinence or a urinary incontinence, if the patient is there in stool or in urine, or the dress which patient is wearing is dirty and is moist, then it is going to cause irritation to the skin, especially in the buttocks area and in the perineal area, and that can also cause redness to that area. And if it is persistent, like in patients who are having gastroenteritis, or who are being given medicine to actually produce diarrhea, like in patients of hepatic encephalopathy. In that patients, we see these things happening very often, and the area of the this buttocks and the perineum getting red. And if it is persistent, then it can lead to big skin ulcers there also. Although it is not a pressure injury, but it also looks very bad. And the important thing is that we have to make the patients understand that this is not a pressure injury, because pressure injury is a quality marker, and this IAD is a different than a pressure injury. Both looks very bad. And the point to remember here is that we should clean the patient as early as possible, and we should keep the area as dry as possible. These are the two most important things to prevent the incontinence associated dermatitis. There is some role of zinc associated creams and using zinc in the diet as well. And these are, I think, important additional things which can also help in preventing or reducing the severity. But keeping it dry and cleaning it as soon as possible is probably the most important thing in preventing IAD. And both IID and pressure injuries, they look very bad, and we must do all the things to prevent these two complications. Over to you, Prateek, for the MCQs.
Awesome. Thank you, sir.
If we have any questions or queries from the participants, they can write in the chat box.
So these are, as Sir has vastly explained everything, and thank you, sir, for always being there and for teaching us. So over some brain teasers. So one of the most important ways to prevent pressure ulcer is, I think you can write your answers in chat box if anyone can write it on it. And Miss Deepa, you can see the answers, or should I post the answers? What I have to do?
Uh, dictate
Sorry.
answer. Answer is in
Yeah.
the chat box.
Okay, so you
Yeah.
will see the answer.
Yeah, we can see on the chat box, Prateek.
Yes, sir.
So Miss Leena has answered option D,
Okay.
to regular
So
repositioning.
okay. So as I've already discussed, one of the most important pathway to prevent the pressure ulcer is the not positioning is your preventive part of starting it. First of all, starting is the finding at risk individuals. What are at risk individuals are. Okay. So these are most important pathway for preventing a pressure ulcers. Second
So,
MCQ is
Prateek, just go back to this one. So, all
sure,
the
sir.
things like doing regular skin assessment, providing support surface, do regular positioning, identify, these are all the important things to prevent pressure ulcer. But probably the step one is the identifying the at-risk individuals.
Sure,
Right.
sir.
So that is why the option C is considered here the correct one. But all of them are important things which can help in preventing pressure ulcers.
Yes, sir. So towards the next question, all at-risk patients should be assessed for pressure ulcer, except
So
all
any of the
at-risk
participants, please
all at-risk
try
patients
to
should be
answer.
assessed
Yeah.
for pressure ulcer, except
So should we assess at the time of admission? Any of the participant? What are the protocols in our ICUs? So again, Miss Lena has answered option D, upon discharge.
oh, yes. So at all at-risk patients should be assessed for pressure ulcer, except at the time of admission, of course, at the regular interval, at any significant change of health condition. But upon discharge is lastly a last point of contact that you can see it. But the most important is at the time of admission, at regular intervals, and at any significant change of health condition. So the third MCQ is
So,
in
so I think
sure, sir.
both the candidate have given the right answer. Very nice.
Yes.
Option B, correct.
So the third MCQ is in acute care, reassessment for pressure ulcer should occur how often? In acute care, a reassessment of pressure ulcer should occur how often? Every 24 to 48 hours, weekly initially, then monthly, every shift, or after patient dies. I have mentioned in my slides.
This should be easy one. Ms. Jyoti has option given the answer, option C. Anyone else?
Oh,
So Ms. Simoli has answered option A. Ms. Lena option C. Okay. So
so the
what
correct
was
answer
it?
is I've already showed you. In acute care, reassessment of pressure should occur every 24 to 48 hours in acute care. If you assess in every shift, it will not change. You can only the positioning and the seeing of that part area is can be seen in every shift. But the change of pressure ulcer or any change in any part is seen or is to be inference in every 24 to 48 hours. Over to you, sir, if anything can be added, sir.
Yeah, I think the confusion here was that the assessment of pressure ulcer. So,
Yes, sir.
so here the question is regarding the grading of the pressure ulcer, the risk identification. Okay, so it is from mild risk assessment to the moderate, like we do it for Braden scale and all. So it is about that thing. So that has to be done every 24 to 48 hours. All the preventive things which we do has to be done every shift. Okay, so
Yes,
these are two different things. So you have to work in every shift to prevent a pressure ulcer, but the assessment whether the grading has increased or not, or the risk factor major change has happened or not, that has to be done every 24 to 48 hours. So that is the difference between the two, and which the Dr. Prateek is trying to ask. So option A is the correct answer.
so the fourth MCQ, if patient or a resident, it's like a patient or any admitted patient or any critical care patient is found to be at low risk for pressure ulcer, further reassessment is not necessary, is like that. As sir already mentioned in their bread and part, also in my webinar now, that whatever the Braden scale is. So if patient or resident is found at low risk, you should not assess it or you should. What will be your answer?
Yeah, so Jyoti ji and Miss Leena, they have also both answered false option.
Yes. So it is right. You have
Yeah.
to, as sir has already told you, whatever the risk is, it is low, medium risk, moderate risk, mild risk, whatever the risk is, you have to reassess in your every shift. It is necessary. Okay. So the fifth MCQ. Which of the following factor can cause a pain when a patient or a resident has a pressure ulcer? Pressure friction shear, damaged nerve endings, inflammation, infection, or all two. Which of the following factor can cause a pain when a patient or a resident has a pressure ulcer? Pressure, friction, shear. Point A, damaged nerve endings. Option B, option C, inflammation. Option D, infection. Option E, all two.
So uh, all the three participants which are actively participating here, they have given option E as the correct answer.
Because all are true is there. Okay. So yes. So which of the following factor can cause a pain when a patient, all residents or a resident has a pressure ulcer? Of course, pressure, friction, and shear is also a painful. Damaged nerve endings, half damaged nerve endings causes very painful. Inflammation and infection, of course, causes a painful because of inflammatory mediators. And yes, all the options are true. Over to you, sir. If anything can be added, sir.
Yeah, so as we see in a burns patient as well, so in the grade 1 and grade 2 burn injuries also it is very painful, but in the grade 4 burn injury we see that because all the nerves are also completely damaged, in that case you won't have pain. So if the patient is having very deep ulcers, he may or may not have pain directly coming from the ulcer, but because of the pressure or the inflammation, all that can also cause pain to the patient. So all the options at various points of interception can cause pain. So all the options are correct.
Thank you, all participants. So next question and mostly last question. So a red wound bed indicates what? This is something tricky, which I also read after this reading an option of MCQ. So presence of slug or a fibrinous tissue, presence of a granulous tissue, infection or sign of ischemia. A red wound bed indicates what?
Ms. Jyoti has given us the answer. Option D, sign of ischemia. Anyone else? Selena has answered option B, presence of granulation tissue.
So the answer is presence of a granulation tissue
Right.
because as we have seen the granule part is always a red. Sign of ischemia is always when there's a ischemia or when there's a less perfusion tissue, it will never the red. It will always a blackish towards it. Okay, infection part is always can be a black or any sludge area is there, and presence of sludge or fibrous tissue as all I have told you the infection part. So the presence of granulation, that is a healing part. Towards the healing, towards the edges of the part, it's a red wound bed it indicates. So this is the red wound bed which indicates that. So this is all my end of slides and end
And
of the presentation. And
so that,
over
that
to
is
you,
what
sir.
the plastic surgeons always want, that a wound bed should be a red one, because that means that the blood flow towards that wound bed is very good, and that is definitely going to help in recovering from that particular wound. And the option D, sign of ischemia. Ischemia means that the blood flow is less. So if the blood flow is less, definitely it is going to be not red, and it is going to be some other color depending on the severity of the wound. And that is what the target for anyone is, that we should grow we should always allow the granulation tissue to grow, and that is all going to improve the pressure injury. Yeah.
So
So is it all
thank you. Yes, sir.
on the MCQs?
So yes,
So
sir.
any comments from the participants? Any questions from them? I think since there are no further questions, and very nicely summarized topic, Dr. Prateek. Thank you so much
Thank you,
for
sir.
all your hard work, and it's always great to listen to you. And for the participants, I would say that this is a very important topic for the exam point of view, and as well as from your practice point of view. And it's a quality indicator of nursing care given to a critically ill patient, and we should always focus on that. And from the exam point of view, this is always a very focused thing, because this is one of the key thing which an examiner is always looking, that as a nurse we should be very much aware of this thing, and we should know what is the pathogenesis, what are the incidences, what are the points where the pressure injury can occur. Especially if we remember that if we do lot of positionings, then different areas of the body gets chances of pressure injury. So we have to be very careful. Dr. Prateek had already said that we see some pressure injuries, especially if we do a lateral position on the ear. We have seen these things happening in our ICUs, and so it is very important to apply common sense, giving padding to all the things which can be associated with pressure injury is very, very important. And preventing is much more important, because once a pressure ulcer develops, it is a very bad looking injury, and it goes to show our ICUs in a negative way, and that we should always prevent. If unfortunately some pressure injury has occurred, then obviously we have to do a lot of other measures so that the injury doesn't get worsened, and it actually goes on to the healing part. So all the things have been covered in this lecture. We can go through all these points, and all the relevant articles have also been shared. You can go through all these articles, and they are very, very will give you comprehensive knowledge about this topic. Thank you.
Thank you, sir, and thank you for giving me this opportunity. Over to you, Ms. Deepa.
Okay. With your permission, I just end this.
Hello.
Okay, sir. So, with your permission, I just end the session. There is one
So
question
there's
in the chat
yeah,
box.
there's a question in a chat box.
Yeah.
Sir,
Sir,
stages of pressure
stages of
sore.
pressure. So, I
I
want to ask you about unstretchable stage. It's been
Yeah.
added.
Acha. So the unstageable stage that I have added. Sir, you want to answer, sir, on this part, sir?
Yeah, please continue, Pratik.
So this, as I have already told you in my the fifth part, that is unstageable. The unstageable is that have already passed on all the stages and not it's hidden. His skin is black or a maroon or a purple colored. Under that part is getting ulcer off. So it's a new stage that is added in 2017 guidelines. There's unstageable, that is unstageable stage, which is that it's not the ulcer is occurring, but the over part is hidden. So it is called as occult or a unstageable. So it can't be staged in not in stage one, not in stage two, not in stage three, not in stage four. But it's another stage, which is the ulcer is already formed. The skin is getting black, pulper, or a maroon colored, but under part is getting ulcer getting detached off. Skin is getting deformed in under part. That is called the unstageable part. That is recently been added in the stages of the pressure ulcer. Not in a Braden scale. You can't count in a Braden scale. You can write in your papers. It is an unstageable stage. Okay, over to you, sir.
Just to simplify it, that there is a skin which is covering the ulcer. Okay, so that is a very like a dead skin or a very deformed skin which is covering, and we really don't know beneath that skin what is the stage. That is why it is unstageable. Okay, so this is the simplification of that. We don't know when we will uncover that skin, which will be the stage. So that is why it is unstageable.
Unstable stage.